Hello viewers, welcome to my channel. I am Puspen Dasgupta, an ENT specialist from India. I upload videos on YouTube at 9 p.m. Indian Standard Time every day of the week. Each day of the week follows a particular theme. The theme for Monday, that is today, is postgraduate ENT, especially postgraduate ENT theory exam. Both during my tenure as a postgraduate trainee and during my tenure as an assistant professor, I felt it was particularly painful for postgraduate students to negotiate the theory exam because often we had to encounter 10 questions in each paper and each question carried 10 marks. The total duration of the question paper was 3 hours, so we had roughly 15 minutes for each answer. To write a 10-mark answer in 15 minutes is no easy task, and often it is difficult to find an answer that is good enough to fetch as many marks as possible, and sometimes the answer we find is so big that to write it in 15 minutes becomes a very difficult task. The most tricky aspect of writing answers is sometimes the answers are not available in not just one chapter but also in one textbook. Sometimes the questions are so difficult that we don't even know which textbook to read it from. So with all this confusion, we do feel a bit nervous. This is my attempt at providing sample answers that you might use as a foundation to write better answers in your theory exams. I hope you will like this video. In today's video, we will talk about a frequently asked question in postgraduate ENT exam, classification of sinonasal tumors and steps of endoscopic medial maxillectomy. For the classification of sinonasal tumors, I have used as a reference Scott Brown 8th edition, and for the steps of endoscopic medial maxillectomy, I have used as a reference Endoscopic Sinus Surgery 4th edition by Peter John Wormald. I hope you will like this answer. So without further ado, let's get into the meat of the discussion. Sinonasal tumors, like any other tumors in the body, can be classified into benign and malignant. This part is easy. In terms of tissue of origin, sinonasal tumors can be further classified into epithelial, neuroendocrine, soft tissue, bone and cartilage, hematological and lymphatic, neuroectodermal, and germ cell tumors. If you are skeptical about my credentials and whether you should believe my answer or not, congratulations, you're just like me. So I should share my credentials with you just to make you believe that I am credible. I obtained MS ENT from a government medical college in India in 2019. I have worked as an assistant professor in a National Medical Council recognized medical college, and I'm also a member of the Royal College of Surgeons of England by the ENT route. So with that out of the way, let's proceed with the answer. Now that we have classified sinonasal tumors under epithelial, soft tissue, neuroendocrine, bone and cartilage, hematological, lymphatic, neuroectodermal and germ cell tumors, let's talk about each individual group. Let's start with epithelial sinonasal tumors. They can be benign, they can be malignant. Now what are the benign epithelial sinonasal tumors? We have the three papillomas: inverted papilloma, oncocytic papilloma, exophytic papilloma, respiratory epithelial adenomatoid hamartoma, and of course we have salivary gland adenoma. Then we move on to malignant epithelial sinonasal tumors. We have salivary gland carcinoma, we have mucoepidermoid carcinoma, acinic cell carcinoma, adenoid cystic carcinoma, adenocarcinoma, lymphoepithelial carcinoma, squamous cell carcinoma, and undifferentiated sinonasal carcinoma. Now that we have covered epithelial sinonasal tumors, let's move on to the next group, neuroendocrine sinonasal tumors. There is only one, carcinoid, and carcinoid is malignant. So there is no benign neuroendocrine sinonasal tumor, there is only malignant neuroendocrine sinonasal tumor, that is carcinoid. Moving on, we have sinonasal tumors of soft tissue origin. They can be both benign and malignant. The benign soft tissue sinonasal tumors are myxoma, leiomyoma, hemangioma, meningioma, schwannoma, hemangiopericytoma, neurofibroma, and angiofibroma. Okay. Moving on to the malignant sinonasal tumors of soft tissue origin, we have fibrosarcoma, angiosarcoma, rhabdomyosarcoma, and malignant peripheral nerve sheath tumor. Let's talk about the other groups. Sinonasal tumors of hematological or lymphatic origin can only be malignant. There can be lymphoma, and there can be Langerhans cell histiocytosis. Then we move on to sinonasal tumours of germ cell origin. They can be both benign and malignant. Benign germ cell sinonasal tumours are dermoid cyst. Malignant germ cell sinonasal tumours are teratoma, sinonasal yolk sac tumor. And finally we have malignant neuroectodermal sinonasal tumor, which is esthesioneuroblastoma. I hope you wrote down everything. Now that we have covered classification of sinonasal tumors, where I used 8th edition of Scott Brown as my reference, let's move on to the second part of the question, steps of endoscopic medial maxillectomy. For this particular answer, I have used 4th edition of Endoscopic Sinus Surgery by Peter John Wormald as my reference. Endoscopic medial maxillectomy is typically performed under general anesthesia. Nasal cavity is prepared by placing 4% lignocaine and adrenaline-soaked neuropathies in the nasal cavity. Lateral nasal wall and septum are infiltrated with 2% lignocaine and 1:80,000 adrenaline. Pterygopalatine fossa block is placed via the greater palatine canal using 2 ml lignocaine and adrenaline to reduce bleeding during dissection of the medial wall of the maxilla and pterygopalatine fossa. Uncinate process is removed to perform a large middle meatal antrostomy. Maxillary antrum is enlarged posteriorly up to the posterior wall of the maxillary sinus. If you have watched my video on orbital complications of endoscopic sinus surgery, then you would know that maxillary antrum, if enlarged anteriorly, can cause iatrogenic damage to nasolacrimal duct. Moving on, medial orbital wall is then visualized and residual medial maxilla is removed without endangering orbit. Inferior turbinate is then medialized. Inferior turbinate is crushed just distal to the junction of anterior end of the turbinate and lateral nasal wall using Tilly packing forceps. A large intranasal component of non-vascular tumor is debulked. So if you are debulking the tumor better be non-vascular. If the tumor is vascular, then it is pushed superiorly. If the tumor is firm, then it is partially debulked. Angiofibroma, which is the most dangerous tumor in terms of vascularity, is usually not debulked because of its posterior location. Inferior turbinate is cut with turbinectomy scissors along the crushed region of the inferior turbinate up to the point where turbinate inserts into lateral nasal wall. Mucosal incisions are made with scalpel from just below inferior turbinate in a way to ensure that after medial maxillectomy, the mucosa can be rolled back over the raw bone of the residual medial maxillary wall at the junction of nasal floor and the maxillary sinus. The bone is cut with sharp osteotome at the junction of medial maxillary wall and nasal floor. A posterior vertical cut is then made in a manner to enter maxillary sinus adjacent to the posterior wall of the maxillary sinus and into the large antrostomy. The bone forming medial maxillary wall is now mobilized. Nasolacrimal duct, which in this case will be tethering the bone anteriorly, is visualized and transected with a scalpel. At the end of the surgery, to prevent post-operative stenosis of lacrimal sac, the lower half of lacrimal sac is opened using a dacryocystorhinostomy spear knife, creating an anterior and posterior flap, which are then rolled out. Entire maxillary sinus is visualized using a 70-degree telescope, including the anterior wall and the floor of the maxillary sinus. Tumor is then removed from maxillary sinus under direct visualization. Now this much is enough for a good answer. However, if you want to write more, because it might carry 10 marks, you might have to write a little bit extra. So, in large tumors which involve posterior ethmoids and sphenoid, axillary flap is performed and frontal recess is dissected with exposure of the frontal ostium. Bulla ethmoidalis is removed, posterior ethmoidectomy and sphenoidotomy is performed, skull base is clearly identified. Tumor extension into anterior and posterior ethmoids is assessed, and if necessary, biopsies or frozen sections of the mucosa from these regions is sent for examination to ensure complete tumor clearance. Now, if additional access is required and tumor does not attach to the anterior wall of the maxillary sinus, a canine fossa puncture can be performed. Remember, canine fossa puncture is performed when the tumor does not attach to the anterior wall of the maxillary sinus. More on this later. Canine fossa puncture allows introduction of instruments or endoscope to difficult to access areas within the maxillary sinus. Further resection of anteromedial wall of maxilla and frontal process of maxilla is performed if anterior face of maxillary sinus is not seen, and better access is required to the anterior face for a tumor which is attached extensively to the anterior face of maxillary sinus. So note here, if the tumor is attached to the anterior face of the maxillary sinus, canine fossa puncture is not done. Why not? Because canine fossa trephine has a small risk of seeding the tumor into the soft tissue of cheek if entry is made through the tumor. So if the maxillary sinus is entered by piercing through the tumor, there is a small chance of seeding of the tumor into the soft tissue of cheek. Now, if access is still difficult and the anterior wall of the maxillary sinus is not fully accessible, a transseptal route is created, which provides a better angle of approach to the surgeon. Okay? So a better angle of approach is found to this region by creating a transseptal route. This access is achieved by performing a hemitransfixion incision in the opposite nasal vestibule and then removing a small horizontal area of cartilage and or bone opposite the region of anterior maxillary sinus. Instruments are then passed through hemitransfixion incision through the cartilage window and then through the horizontal mucosal incision in the opposite nasal cavity, giving greater access to the anterior wall of the maxillary sinus. This approach improves angle of approach and usually allows complete access to the entire anterior maxillary wall. It is the best way to approach this region, and it can be done using either a 60-degree microdebrider blade or a 70-degree diamond burr. I hope you liked this answer. I spent hours preparing this answer. I hope you liked it. If you want me to answer any other questions that may have been bugging you, please feel free to mention it in the comment section below. I hope I'll see you in the next video very soon. Take care, and please don't forget to be awesome.